As many of us are so keenly aware, the urologist has been the purveyor of prostate cancer management, primarily in the early stages. I don't really see that changing unless we, as a specialty, allow it to be taken from us. Consequently, the prostate cancer patient is accustomed to seeing his urologist for routine follow-up. As we know, 30% of early-stage patients definitively treated for the disease will fail. Identifying those patients is troublesome, as there are no firm guidelines or protocols currently in place. The importance of developing pathways for identifying and monitoring these patients revolves around the fact that we now have many new therapies that show a survival benefit in this population. Additionally, these newer oncolytics can be delivered by the practicing urologist, given the existing physician-patient relationship. Let's talk about prostate cancer screening first, which, based upon some recent government regulations and recommendations, is a little bit of a lively topic. So, Dr. Crawford, let's start with you. And we know that the United States Preventive Services Task Force came out with a very controversial recommendation talking about the use of PSA in the general public as it relates to the early detection and screening for prostate cancer. Your thoughts?
Well, the short answer is I think there's a lot of truth in what they said. Backing up, we started something called Prostate Cancer Awareness Week in 1989. It was the first big organized national screening event, and it's been in place since then. It's grown. Millions of people have been screened. We've learned a lot over the years. We saw the pendulum swing from advanced prostate cancer at diagnosis to early. And then what happened is, this is where we got into trouble, is that we were diagnosing a lot of people that maybe didn't need to be diagnosed and treated. And that's always been the difficult thing. This U.S. Service to Preventive Task Force recommendation has been a long time coming. This has been going on for a decade. They attacked over 70 years old. They question it. And they've been looking at this, and a lot of groups have for quite a while. I was part of one of the 10 screening sites for the PLCO trial that has been attacked by many people. There's a lot of truth in that trial, and I think we have to look at it. The bottom line is we need to separate diagnosis from treatment. Not everybody diagnosed needs to be treated. We need markers to determine. And just in this month's Journal of Urology, there are a couple of papers about who benefits from radical prostatectomy. It's the people with, not very minimal disease. And, it's the whole active surveillance issue, which we don't do much of. And so it's a very difficult thing. So what's happened is, I think the biggest danger in this, screening is not going to go away. I've been around long enough to see the attacks that have come on screening by the ACS and others over the years. And what it does is it actually generates more interest in screening, and people come in and say, well, that doesn't apply to me. I want to get it done. And I have not had any patients, maybe one or two, that have said something to me. I think the biggest danger in this is going to be what happens with family practitioners and internal medicine. They are looking for a reason to get out of the prostate screening arena. They don't understand it. It's the basis of many lawsuits and overdiagnosis and overtreatment. They see a lot of this. So, what we need to do is find a common ground. Some of the organizations, the AUA, I think they should react to this. I don't think we should overreact. I'm not sure that we should be attacking the U.S. Services Preventive Task Force, United States Preventive Services Task Force. I think we should be working with them they didn't say we should really stop screening. We should talk to patients about it and find the right one. So we really ought to work on better ways to identify who needs to be screened. I presented some stuff at the meeting from the PLCO grant saying, hey, well, wait a minute. Maybe we don't have to screen every year. And they actually said this in there, if you read their transcripts, is that maybe we could do some things to make it worthwhile. And the study we all quote as being a positive study, the European ERSPEC screening study, they screened every 4 years. We do it every year, and we did it in the PLCO. Maybe that's too much. And What we showed is by screening every 5 years at a select group of people, you could save $1 billion a year. So there's a lot of things out there I think we should work on and get away from this. If you don't believe you overtreat and overdiagnose a lot of people, then I think there's a problem. I see it all the time. Somebody comes in, they have a PSA of 4 or 5, and they have a Gleason score of 6 in one core, and they get a robotic prostatectomy or IMRT. And then when you do the prostatectomy, you see this little teeny area. Did that person really need to be treated? So the pendulum needs to come back a little bit.